Hello everyone. In this short video on Macleod series, I would like to discuss about diagnostic approach to breathlessness. In your university practical examination, from respiratory system, you will be getting either pulmonary fibrosis or lung collapse, bronchiectasis, consolidation pneumonia, very rarely lung abscess. So bronchiectasis, consolidation pneumonia, lung collapse and pulmonary fibrosis following tuberculosis. So these are the very commonly kept cases. And the examiner used to ask lots of questions, more or of clinical importance, especially from this table. That is why I have taken this table from Macleod's textbook of clinical examination and I thought of discussing in a short. So, whenever comes breathlessness, you have to either classify them into chronic or acute or subacute basis. So, coming to the acute onset breathlessness or subacute onset breathlessness, it may be either sudden or it may be either progressive. So, sudden means the patient is otherwise normal. Suddenly he is getting an episode of breathlessness, and when this sudden onset breathlessness is associated with pleuritic pain, and in examination you found that the patient has hemoptysis, swollen leg, you have to think, why swollen leg? Because deep vein thrombosis is one of the most important risk factors for pulmonary embolism or pulmonary infarction. And at the same time, when this pleuritic pain is associated with absent unilateral breath sounds on clinical examination, once you place your stethoscope, you will find that on one side of the chest, the breath sounds are completely absent. You have to think about pneumothorax. And at the same time, when the sudden onset breathlessness is associated with crushing central pain, and on examination, crackles. Remember, very, very important, crackles are something you will get either in bronchiectasis or in pulmonary edema. And at the same time, when the crushing central pain is associated with normal breath sounds with the raised JVP, we have to think about large pulmonary embolism. That is, the patient will be having an impending heart failure. Suppose the breathlessness is progressive over hours or days. Sir, initially it was normal. We have the MMRC grading for breath, dyspnea for respiratory disorders. Yes. So, initially it was, sir, only with severe activity when I am doing, I will be getting breathlessness. Now, not even at rest itself, I am uncomfortable. So, progressive breathlessness with fever, cough, always think about consolidation pneumonia. And when it is associated with wheeze, you will get acute bronchitis. Okay, acute bronchitis most commonly of viral etiology. Suppose if progressive breathlessness is associated with tiredness, atopy, risk of allergy, recurrent episodes over seasons. Okay, sir, even in cold climate, I am getting exacerbation. Always think about asthma. Okay, asthma, the patient will be having recurrent episodes and the patient will be having wheeze. Wheeze is an examination finding either in acute bronchitis or in case of new onset asthma. Suppose this breathlessness is insidious onset and it is associated with weight loss, cough, and in that unilateral dullness, clubbing, you have to think about malignant pleural effusion, and crackles or night sweats, again you have to think about tuberculosis. But remember, crackles mainly we say in case of pulmonary edema as well as in case of bronchiectasis. In tuberculosis, tuberculosis is actually not just by a single examination finding we come to a diagnosis of tuberculosis. The ultimate gold standard investigation for diagnosis of tuberculosis, of course, CBNAT. Okay, CBNAT, we have to do sputum culture. Okay, then it has to be combined with X-ray findings and all. But ultimately, CBNAT that decides the patient is having TB or not. So, weight loss and cough, either think about remember, clubbing in respiratory system, you have to think about bronchiectasis. In bronchiectasis, you will be having clubbing. In malignant pleural effusion, not in simple pleural effusion. In malignant pleural effusion, the patient will be having clubbing. And in the other case, we have lung abscess, empyema thoracis, bronchopleural fistula. So, these are the various respiratory system conditions where you get clubbing. It is a very commonly asked question. Suppose the patient is having dry cough with fine inspiratory crackles. Yes, fine inspiratory crackles are hallmark of interstitial lung diseases, so called as the occupational lung disorders. Okay, dry cough. So acute onset or subacute onset. That acute breathlessness will be either sudden, if with pleuritic pain, hemoptysis, think about pulmonary embolism, unilateral absent breath sound, things about pneumothorax, crushing central pain with crackles, MI with pulmonary edema, with raised JVP, impending heart failure, progressive breathlessness, fever, cough, things about consolidation pneumonia, tightness, atopy, think about asthma or acute bronchitis. Insidious onset, weightless cough, unilateral dullness, clubbing. Remember about malignant pleural effusion. Remember, fine inspiratory crackles, dry cough is pathognomonic of interstitial lung disease. It is actually a very commonly given hint in your clinical examination. Unique case scenario in your theory exams. Then coming into the chronic etiology. Angina, frothy sputum occurs at rest or night. Again, remember crackles, congestive cardiac failure, right? Well, frothy sputum means impending what pulmonary the patient may what end up in heart failure anytime, and the patient will die because of pulmonary edema. And again, tightness, asthma. See, asthma, acute exacerbation of chronic asthma is acute onset breathlessness, whereas usually asthma is a chronic etiology only. Okay, but when the patient is having acute onset, that means there is an acute exacerbation of chronic asthma. And again, paresthesia, can't get enough air, corpopedal spasm, anxiety, hyperventilation. That is, the patient will be having hypocalcemic tetany. The patient will be gasping air. Then exertional breathlessness, smoker, hyperinflation lung, think about COPD. Again, I told you, dry cough, fine inspiratory crackles, interstitial lung disease. Again, interstitial lung disease is of chronic etiology, but the patient will have acute exacerbation. In that case, the patient will have present with the acute onset breathlessness. So interstitial lung disease, always remember fine inspiratory crackles and dry cough. Okay, then angina, frothy sputum, crackles, peripheral edema, congestive cardiac failure, impending pulmonary edema. Fever, cough, green sputum, think about consolidation pneumonia. Pleuritic pain, hemoptysis, swollen leg, remember about pulmonary embolism or infarct. Okay, and remember, if chronic breathlessness, that too exacerbated during night, again pulmonary edema, impending cardiac failure. Okay, so this is a very, very important table from Macleod. Make sure that you know this flowchart in detail, so that any questions by the patient's history and examination findings, you can come to a diagnosis. Thank you.